We have Dr. Okay, we've got Dr. Tom Nyirenda and we've got Dr. Mas Chaponda. Before we start, I would just like to, I'm going to ask our Vice President to say something, a little something about what we've been doing so far as Muna. But before that, just a few housekeeping, which I'm going to repeat a bit later on for those who are going to come later on. So first thing is, we are recording. So if you do not want to be on screen, you're more than welcome to turn your screens off, but we would prefer it if people would have their screens on. Please mute your mics unless you are speaking. And if you do want to speak, do raise your hand. We are going to have a chance to ask questions later after everybody has had a chance to speak. So we will have a moment where people can ask questions. In the meantime, if you do have any pressing questions, please use the chat function and we will pick up questions as we go. If you want to keep yourself anonymous, once again, you can always send a question directly to me or to either Patrick or Charity, and we'll pick it up from there. Welcome. My name is Sala and I'm a member of Muna, and today is going to be a fantastic day. So I hope you've brought your A game, you've got questions, you've got queries, and you're open for discussion. So please keep your ears open and we would welcome all your questions. Patrick, would you like to say something before we kick off?
Yeah, not much though. Yeah. Anyway, Happy New Year to you all. And I would like to welcome you all to this very first webinar in 2022. Welcome to our presenters. As Sarah said, we have Dr. Masa Chapunda and we have Dr. Tom Nyirenda. And we are also privileged tonight that we will have our own Charity, our president, being amongst the presenters. Dr. Chaponda and Dr. Nyirenda are not new to Muna. They were here, they helped us deliver some sessions last year, and it has been good for them to join us today again. On behalf of Muna, I would like to extend sincere gratitude for you, Dr. Masa Chaponda and Dr. Nyirenda, for being there for us. With COVID-19, we are living in unpredictable times. Sometimes we may have some hopes, thinking that tomorrow will be better, but ending in vain. Having worked tirelessly last year, putting lots of interventions in order to control COVID-19, we thought possibly 2022 could be much better. But what did we have? Another variant, Omnicron. So this means that we still have lots of things to do. We still have to put some more measures. Hence, having this webinar today, focusing on Omicron and vaccinations. Those living in UK, I think we have a privilege here because we have lots of resources. And I think for the time being, most of people living in UK have had vaccinations. But in Malawi, I think we are faced with tooth problems, hesitations, plus lack of resources. We know in our country, vaccination is still a problem. We don't have much, only few available and only few have received. So in this webinar, we just want possibly to share some sort of knowledge so that we can enhance measures which we started implementing last year to enforce the messages, to encourage people get vaccinations. So I would like possibly all of us to be attentive, to listen to our presenters and take whatever they have prepared for us. Thank you very much. Thank you, Sarah.
Thank you, Patrick. I think I'm going to be the one person who might play devil's advocate. So in our communities, people are asking lots of questions. We have people who are very hesitant to get the vaccine and people who refuse point blank to have the vaccine. So today's webinar will answer some of those questions, or it might raise a few more questions. So please be open to asking questions. This is a discussion. This is so that we shall inform ourselves. We want to be a well-informed community so that when we make decisions, they are evidence-based and they're not just coming from hearsay, they're not coming from scaremongering. And as professionals, which a lot of us are coming from the medical field, we have, I believe, a civic responsibility to our patients, to ourselves, and to our families. So without further ado, I'd like to introduce our very first speaker, Dr. Mas Chaponda. As Patrick has stated, we've had Mas from almost 2 years ago in 2019 when we initially started, and he's been with us, continuously supporting what Muna does, and we absolutely appreciate his support. Dr. Mas Chaponda is a senior infectious disease consultant and senior lecturer at the University of Liverpool here in the UK. He is an honorary research fellow at Liverpool School of Tropical Medicine with training in general medicine, infectious diseases, and clinical pharmacology. He has interests which include blood-borne viruses and clinical trials. So, Dr. Chaponda, the floor is all yours, or should I say the screen is yours.
Thank you very much, Salah. Can I just check, Salah, can you hear me all right? And can you see my shared screen?
Yes, I can hear you. And yes, I can see your shared screen.
Thank you very much for inviting me. Thank you to Muna for putting this all together. I'm going to talk for about 30 minutes, well, maybe less than that. As before, it will be more of a question answer that I'll be using, and then I think there'll be some overlap with what Thomas has to say, and then I think we'll take questions at the end. I think that's the format. So my talk, I've split it up into three: it's the good, the bad, the ugly. I think you'll remember the movie by Clint Eastwood. So I'm going to talk about, firstly, I'm going to change the order. I'm going to talk about the bad aspects of Omicron, and then I'll say some of the good things that we've learned and what's coming out, and then about the ugly and where we are. And that will be the format. So I'll start with the bad. Bad news is always good to get it out of the way. So we're at 332 million cases, confirmed cases. This is from the WHO data, with over 5 million deaths. And you can see the waves there from the alpha, the beta, and the gamma, then the delta, and then more recently Omicron. And if you have a look at this again, this is now showing the same thing, showing the different waves. And depending on where you are, this is your third or your fourth wave. But you can see there for the global trend for Europe, Americas, South Asia, Eastern Mediterranean, West Pacific, and Africa right there at the bottom. When we focus on Africa, you can see there over 7 million cases in Africa. And here the waves, as you would call them here. So there wasn't much of an alpha, but then there certainly was a beta, then the gamma, then the delta, and then more recently Omicron. And as you can see, each wave getting bigger and bigger, the biggest being Omicron, and that's the bad, certainly. This is the UK data. And again, not a pretty curve. It's not as clearly humped as in many of the waves merged into one here, certainly the Delta, and then Omicron taking off there. So this is right from the beginning of the pandemic going across. This is the data from Malawi. I won't talk much about that because I think Thomas will talk about that, but certainly 1, 2, 3, 4th wave. And again, predominantly driven by Omicron. So the variants, we had the Victoria original strain, and then we've had the Alpha, which was originally identified in the UK. Then we had the Beta from South Africa, originally identified there anyway. Then the Gamma in Brazil, then the Delta in India, and more recently the Omicron, which was first identified in South Africa, but actually it's widespread. And these are all different changes in the virus, and the virus keeps changing. More recently, we have this Omicron, which is a whole different beast on its own. It's got bits and pieces from Alpha, bits from Beta, Delta, and wastewater, so water that was found in California. There are bits and pieces there, all sorts of changes, which essentially mean the virus is able to infect more quickly. It grabs onto the host and it stays on, and it can evade immunity. It can evade vaccines, and I'll come back to that. So over 50 different changes which have made this variant more infectious and made it more resistant to vaccines. So it is highly contagious. It's burnt across the globe like wildfire. It multiplies in the upper respiratory tract, so up in the airways, 70 times faster than Delta over the first 24 hours. So in terms of how contagious it is, once you get infected, it incubates in you for about 3 days. You're infectious in those 3 days and you're then symptomatic. While Delta is a bit longer, it's about 5 days. So this comes on very quickly, making it twice as contagious as Delta and 4 times as contagious as Alpha. As I mentioned, that it can, because of those mutations in the S protein in its membrane, it can, vaccines are not as efficient at preventing infection, stopping you from getting the infection. So they're 41-fold less able to work, the vaccines, i.e. in English, that means, for example, Pfizer, 20% from the 95% that we knew before on the original virus, 20% effectiveness after 2 doses against Omicron. Okay, so you can see that it's the Pfizer vaccine, for example, is better against Delta, less against Omicron. That's 2 doses, even after 2 doses. And we can look at the different vaccines. So you can look at Oxford AstraZeneca, you can look at Pfizer, Moderna, Johnson, all of them, the efficacy at preventing you getting the infection drops, and it drops quite dramatically. It drops, for J&J, for example, to less than 40. Moderna also drops. Pfizer, as I've said, AstraZeneca, they all drop. And there is a potential to overwhelm health systems, and we've seen this purely because this is highly contagious, so many people get it. And if many people get it, it means that there will be many in that subpopulation of vulnerable who will get admitted. So the sheer number of cases can overwhelm unprepared health systems, and we've seen this in many parts of the world. The other thing that we've seen, which is different from the other variants, is that we've seen a record number of hospitalizations for children, and that's interesting. So those are really the bad aspects, that it's highly contagious, that you can transmit when you're asymptomatic, you will transmit earlier, you will be symptomatic for about, for the first 3 days you'll be transmitting before you're symptomatic, and then by 3 days you'll be symptomatic, so quite quickly, and you're still transmitting at that stage. So I'm going to move on to the second part, which is really the good aspects that we have learned coming from COVID. So firstly, the explosion of knowledge. If you go from 2017 to 2021, the number of papers that have been published, the scientific world, there's a lot that we've learned about vaccines, about human nature, about the biology. So we've learned a lot, and this will make us more prepared for future epidemics and pandemics. So another good thing about Omicron is that it's going down. So the surge of infections caused by the Omicron variant is leveling off. Certainly it's leveling off in the UK, and it's even falling in some areas. And certainly Thomas will talk about the South African experience, which showed something very similar that the UK and other parts of the world are describing. And actually, the peak may be a bit earlier than we anticipated. So we thought maybe this will go until about March, but I think we may have peaked and we are going down with numbers, or shortly going down. So this means Omicron is the shortest surge in cases to date, as in sharp up and real big surge up, and a peak and going down, and that's a good thing. That's a good thing. And many areas, if you've been listening to the media, certainly Scotland, Wales, the UK, England, which had introduced very tough restrictions, are thinking of lifting things as soon as Monday, in fact, easing of restrictions because of seeing this downsurge. The other good thing that was described in South Africa and has been described elsewhere in the UK, in Denmark, and many places now, is that you have less severe disease. So it multiplies, Omicron more than 10 times less efficiently in the lungs. So it's not good at attacking your lungs, and that's a good thing. So that means there are fewer people who are getting bad pneumonias, fewer people requiring oxygen and intensive care compared to, say, Delta or the other waves. Most people will have a scratchy throat, not much of a cough, and very different from Delta and the others, that there's no loss of taste or smell. So you'll see on my caption there that the scratchy throat and body ache has really become, well recognized as this is Omicron, and 60% of people are asymptomatic. The bad thing about asymptomatic is you can still transmit the virus, but it's a good thing that 60% are asymptomatic. No loss of smell in majority of people, and very little severity. It's not that it's non-existent. There is still some people who get severe disease, and just the fact that many people are getting infections means health systems are overwhelmed. What I mean by that is a lot of staff, nurses, doctors, admin from the health systems are off because they have infections and they can't come in, and therefore there's shortages of manpower at work. The good thing we've seen with Omicron is lower hospitalizations. Although we are saying there are a lot of people who are getting the disease, but we've seen data from all over, South Africa, which Tom will talk about, from the UK, from Scotland, 2/3 reduction in the risk of hospitalization from Omicron compared to Delta. So Omicron is certainly milder disease with milder outcomes like hospitalization. And South Africa certainly reported first the lower risk of hospitalization from Omicron compared to other waves. So another thing that is good, although I said the vaccines don't work at stopping you getting the infections, so you still get the infection, what we call breakthrough. The virus is able to break through the vaccine and you get infected. You get a mild illness. And what we know is the first doses, those primary doses that you got, the first and the second doses, that those doses retain protection. They retain protection against severe illness and hospitalization. So the reason why lots of people are not being admitted, one, it's a milder disease that doesn't attack the lungs, but two, those first vaccines did the job of protecting you against severe illness. We know this. For example, BCG doesn't stop you getting TB, but it stops you getting severe TB, like TB meningitis. Very similar. So this is nothing new that has come from vaccination, but we know that it might not stop you getting Omicron, but it stops you getting severe illness. So although Pfizer, we said it drops to like 20-30% efficacy of stopping you getting infection, it's still 90% effective at stopping you getting severe illness and death. AstraZeneca, 70%. These are very good numbers. So the mantra is that vaccines are not disease preventing in this setting, but they offer protection from severity and mortality. And that is why the message for us that we should be passing on to others is get vaccinated, because it stops severe disease and death. And you can see here from this caption, AstraZeneca, the vaccines that have been given out so far, CoroVac, Pfizer, Sinopharm, etc. There's still a big gap, especially in Africa and in low-income countries. There's still a gap, but there's still a need to vaccinate and a justification. The other good thing is that boosters do work. Boosters do work. When you have had your booster, so 3 doses, so your primary, secondary, and then your booster or your third dose, you get up to 80%. So from that 20% from just 2, say from Pfizer, you go up to 80% protection against infection by Omicron after a third booster dose. So that third booster really pushes it up. The other good thing we've learned from different countries, some of it was maybe due to lack of access, but some of it, from Oxford, for example, they did some trials, is that you can mix some of these vaccines, and that some of the immunity that's generated, the T cells, is much better with mixed vaccines. So we know that after the first dose of AstraZeneca, then you can mix with Pfizer and followed by Moderna, slightly different schedules, but what you get is really good immune responses. So that is useful, especially if we're thinking in countries where we might not have a constant supply, for example, of AstraZeneca or Pfizer, that you can mix and match. Looking at the caption here, you can see here the approved ages. We'll come back to that. The primary course, you can be given with Pfizer, Moderna, AstraZeneca. For immunocompromised patients, that includes HIV, but patients with decreased immunity, a third dose is recommended quite early, actually, not having to wait. And a booster dose is ideally with an RNA, so with Pfizer and Moderna, that's where they've done the trials. But if necessary, if these two are not available or contraindicated, then AstraZeneca can be given as a booster. In terms of yourselves, you can book a booster dose if it has been 4 months or longer since your second dose. So we used to say 6 months, and we said 5 months then, so you can get that booster as early as possible. We'll pick up some of these in question time. I just want to get through the main questions, and then we can have a more discussion back and forth. So apologies if I'm rushing through this. How young can you vaccinate? I showed you here that, with Pfizer, you can go right down to 5. With Moderna, 12 years old. AstraZeneca is 18. So COVID vaccine is available for children age 5 and up. And boosters are now authorized for those 12 years and older. At the moment, trials for vaccines for children age 6 months and up may be authorized very soon. Clinical trials are certainly underway, and I've seen some of the preliminary data, and it looks good. And therefore, thank you, Salah, for that anti-vax devil's advocate stance that you took, because it gives us the opportunity to say these vaccines are safe. The data we're seeing is very good in terms of safety. The numbers are reassuring. Side effects are mild and tolerable. And therefore, we should be the biggest advocates. We should be the biggest advocates for vaccines, no matter whether they're vector or RNA, and for boosters. What about this booster? How long does it last? And my father asked me, does this mean we need to have boosters every month? And is there any time we're going to have to stop? So we know that 10 weeks after the booster, the third dose, protection against symptomatic disease. Again, symptomatic disease might not be a good marker, because we really, the better marker is hospitalization. But protection against symptomatic disease drops even after the third booster by about 50%. So yes, boosters might be the thing that's needed. Protection against hospitalization remains high. That's the important thing. Protection against hospitalization after that booster remains high at 83. Therefore, a fourth dose to people with severely weakened immune systems is recommended. And in Israel, actually, they've started already the fourth dose in terms of the second booster, i.e. the fourth dose. And in addition, Pfizer and Moderna say they are continuing to develop, specific vaccines against Omicron and whichever variant comes along. You may have heard about the IHU variant, which was described in South France, probably from Cameroon. All I can say is that that's not really a variant of concern at the moment. There are a few doubts about that study. That doctor himself, who described this, has not been vaccinated. He does not believe COVID is deadly, and he treats with hydroxychloroquine, all things that have been disproved. And therefore, this IHU variant, everyone is sort of saying, not really too worried about it. And that's all I'll say about that. The last good thing to talk about is that this might be the beginning of the end. I think we are hopeful that it could be the start of a trend that eventually makes the virus milder, like a common cold. So we're seeing that from Omicron. We're saying it's less severe, less hospitalization. Maybe we're going into a phase where we just say, this is something we live with. This might be the beginning of the end. Finally, for 5 minutes, I'll just talk about the ugly truth that remains, having said the bad and having said about the good, which is really good. But there are some ugly truths that this is the Greek alphabet. Okay, we have learned about the Greek alphabet. If you didn't go to Kamuzu Academy, you certainly have now. You've learned about the Greek alphabet, and get ready to learn more Greek letters. So we do not think that Omicron will be the last. It won't be the last version of coronavirus. Many people say, oh, this is the end, because everybody will get immunity. But we know that some variants are there because of persistence of infection in people. And that persistence of infection gives the chance for the virus to mutate. Whether that's in someone who has a weakened immune system, so they're failing to clear it, therefore it mutates and you get a potent mutant, or whether it's coming from animals is not clear. So remember I talked about wastewater in California, where they saw in the water from animals, rats, etc., they found evidence of mutations of the variants. In any case, we do not believe that this is the last of the Greek letters. There was probably one or two more. But we're hopeful that we're getting close to living with the virus and coping. So with both Omicron and Delta circulating, there is that risk of a hybrid. So we know that Delta, nasty, Omicron, less nasty, but there could be some sort of hybrid. We know Omicron has borrowed a lot from all the others, and therefore there could be something that's yet to come. And unfortunately, as the introducer and moderator spoke about this, vaccine hesitancy still out there, and we know that ICUs are full of Delta, ICUs are full of unvaccinated, and we've stopped calling them ICUs, we're calling them the unvaccinated unit, hoping that people will get the message. The unvaccinated are the ones who are ending up in ICUs. Can you get Omicron twice? And the answer is you can, maybe even 3 times. If the first Omicron was not severe and your immune system was not stimulated enough, potentially you can get Omicron twice. If you look in the media, there's lots of anecdotals of people who said, I had Omicron and then 3 weeks later I have it again, that sort of thing. So interesting. So I'm going to end there to allow for the second speaker to speak and to have lots of time for questions. What I would say, we need to vaccinate. Precautions to reduce the spread of Omicron and other variants: get vaccinated, wear a mask, avoid crowds if you can, washing your hands, keeping your social distance, and then looking at cough and sneezing etiquette into your tissues and into your elbows. Thank you very much. I'm going to stop sharing my screen and pass it back to you. Thank you.
Thank you so much, Dr. Maschaponda. I think what you've done, you've just laid the groundwork for all of us, because like you said, we are hearing of so many different variants coming out. And yes, we are going to learn the Greek alphabet, whether we want to or not. And we have to keep our eyes out that we should expect more. I have a few questions, but I'm going to keep them until the end because I assume they might be answered maybe by our next speaker, or Charity might touch on them. But there is that, I think one of the biggest fears, especially amongst professionals, is that vaccination as a condition of deployment that's going to come out, I believe, in April, and what will happen to our colleagues who choose, because I always say people have a choice with vaccines. It is a choice. And I will keep insisting, and when making a choice, ensure that you are informed and ensuring that you're making the decision based on information that is evidence-based before you make that ultimate decision of whether you want to have a vaccine or not. But ultimately, it is a choice. And I have come across doctors, nurses, or any other healthcare professionals who choose not to be vaccinated. And the question is, what will happen in the next 2 months? So keep that at the back of your head, because I know people are gonna, come at you later on with questions around that. Thank you very much. I am gonna ask our next speaker to get ready. So we have Dr. Tom. Is Thomas on your screen, sir? Dr. Thomas Nyirenda, who is actually in South Africa at the moment. So Dr. Tom Nyirenda is works in strategic partnerships and capacity. He is a development manager of the EU African program of European and Developing Countries Clinical Trials Partnership. That's the EDCTP. mouthful. He has a public health position and is a research scientist with 26 years of experience working in sub-Saharan Africa. So you are fit to wear the hat to be able to speak to us today, Dr. Tom Nyirenda. I am going to try and share my screen because I got your presentation that Charity sent. Welcome. Let me just get my screen up. Now I'm going to be questioned on my presentation skills. Okay. There you go. I don't know if you'll have a chance to actually, well, just let me know when you want me to scroll down because it's a PDF presentation.
Oh, okay. I'm sorry about that. I could share it from my side if you don't. Would that be easier for you?
Yes, I think that would be easier if you do. Then you can control it.
Let me try to share my screen. Okay, so if you unshare yours, then I'll try mine.
Salah, can you hear us?
Sorry, you're muted, I think. Yeah. Sorry, you're muted.
Oh, my apologies. I've stopped sharing.
Okay, let me try.
Or has it said pause sharing?
Yeah, it's, yeah, you can go ahead from your side, no problem.
Okay. My apologies. I've taken over.
No problem. Okay, so now I would like to thank Muna again for inviting me in these very important discussions. And Dr. Mas Chaponda has done a very good job to lay the ground. And where I was going to repeat what he said, I'm going to jump the slide, but I don't have many slides. I think I'll take it to be really brief. So if you go to the next one, that just shows what I prepared to share, the emergence of the variants and some statistics on the burden of disease as of last week or this week, beginning this week, in terms of the cases and Omicron spread and also the vaccines, and try to bring in a discussion about that, because I know in the UK you're talking about mandatory vaccinations and what implications it will have. But as you see from my presentations, we have a different scenario in Africa. And that also needs to be taken into account if we have to defeat this disease globally. And some important lessons, and then Charity wanted me to talk about the public health implications as we see it on our side, and I'll conclude. So we can quickly go to the next one, Salah. Yeah, so this, as you can see, Mas Chaponda already talked about this, but this has an important observation, especially in surveillance and how the world works. So as you know, especially in 2020, we were busy doing our own things and setting up our own networks on how we can do genetic surveillance. And of course, people are picking up strains. And as he said, by December 2020, we started seeing these changes of Alpha, Beta, then Gamma in Brazil. And then in 2021, when we thought things were okay, South Africa and Botswana published this revelation of the Omicron variant that shocked the whole world, and Africa was almost shut down and excluded from the rest of the world because of that liberation. But as Maz said, basically, we have now an analysis of those cases, and in several publications, because when the announcement was done in November, South Africa had already started seeing cases rising. And this was not something that was unexpected, because scientists had already started talking about this third or fourth waves, well before they happened. So when we started picking up a lot of these cases, South Africa, put them through the genetic testing that they are required to go, and just to be as a global citizen, to be as transparent as they could as possible. So in one publication you see in the BMJ, from 1 October to 6 December, there was an elevation of 161,000 cases, and these all have been looked at. And that's where now we have the data that Dr. Mas Chaponda is talking about, for example, of now looking at the severity of disease, that we know that the Omicron variant infected patients, or they accumulated in a very short time, but the severity of disease was not as bad. But hospitalization was, when hospitalization happens, the outcomes are much better compared to the data infected patients. And the same studies have continued that show that, like Dr. Chaponda said, that there is a lot of non-symptomatic carriage. And all this has been fed into the world to start together to understand the behavior of the epidemic. I just wanted to highlight that because these points in history of disease control are very important and sometimes are quickly forgotten, and we have to relearn these processes when another epidemic comes. So I'll touch on that in one of the slides later on. So you can go to the next one, Sarah. That's right. So as you can see, as of the beginning of this week, this is how the global burden of COVID-19 really looks. And if you see on the scale at the top of the slide there, many countries, and now it's a common thing that it's not the problem is not South Africa, but it's just that's the nature of the epidemic. Are seeing between 50 to 500 cases per 100,000 still, and this is a 28-day average. A little bit worrying thing in the US and in Australia, but if you think at the way information is collected and shared, maybe the worry should shift to Africa, because it looks like they are reporting very few cases. And we need to look internally whether this is true reporting or some countries have been fatigued and they're not actually sending data in a way that it should be sent, which is possible at the moment. For example, we know our neighbor in Tanzania, we hardly get data from there because they stopped testing at some point. It was a presidential order. So such a map sometimes can be deceiving, but we have to bear in mind the local context. If you go to the next one, please. That's right. So that's the same picture, but in kind of linear format. And Dr. Chaponda went into these spikes of the waves, but you can see the transmissibility and the accumulation of cases, even in UK, that really high spike. This is per million of population, just to amplify the chart. But similar in many countries, and for some reason in other countries like India, not as badly affected as the other European countries. So the next slide, please. Yeah, so now this is a global data as it is being analyzed, and this is of us this week on Monday. If you look at the spread in terms of the percentage of samples that are coming out to be Omicron, again, you can see Russia, United States, and also UK, Australia, and others being really predominant strain in all the samples. But in most of Africa, where Malawi is doing quite well there, as you can see as well, but in most of Africa, it looks like there isn't really good data that we can rely on. But at least we have a feel that it can be a mixed infection, but predominantly what has driven, as Dr. Chaponda said, the fourth wave is really the Omicron. The next one, please. Yeah, so if you look at the deaths, really, again, globally, you can see that what Dr. Chaponda said doesn't really just apply to UK, but also globally, you can see that the number of deaths per 100,000 is really not as bad as it was in the other waves. I think we can go quickly to the next one. Right. So now here it is by Monday this week. There's 15 billion doses ordered from pharmaceutical companies, and here the point is you're talking about vaccines being obligatory and also being used as a barrier to occupational space. I don't know how you can do that in Africa. So the more red your country dot is, departing from the blue, the more you have, the less you have of doses that your population, the unvaccinated, require. So you can see the majority of African countries, although they have been provided with vaccines, but it's less than 2 doses, meaning even if they vaccinated everyone, it would be very difficult to have a second dose, and then a booster is probably inconceivable until things change. But the point also I wanted to bring that also Dr. Chaponda brought about is that this is not really a bad thing. You can see that epidemiologists think that still up to 75% of people survive the infection without no signs and symptoms. And those people get natural immunity. And in these kind of areas, we can rely on that whatever dose they get from a pharmaceutical product is a booster of an ongoing or already, an infection that already happened. The problem is we don't know. And so that's where the drive to still vaccinate people needs to be still be emphasized even in this kind of settings. Next slide, please. Yeah, so from the few slides that I've mentioned, what are the important lessons we have learned? And also speaking from the South African side, we have seen that variants can emerge suddenly, and Dr. Chaponda talked about the Greek alphabet that we haven't exhausted yet. And what does this mean? It means that we have to be ready we have to be still connected. We have to work together, and we have to be ready to share data and make this global surveillance a reality, which at the moment, it has a lot of holes in it. And the second one is that the fourth wave was indeed predominantly Omicron, but the percentage of this mix varies from region to region, and it has important implications in terms of the efficacy of vaccines, as Dr. Chaponda mentioned earlier. There is indeed a global decline, as he said, and also a decline in terms of people who have severe disease and severe outcomes, including deaths, which one death is already too much, but compared to the previous peaks, we are seeing much less. And as I said, vaccination rates and ordered vaccines are still low, especially in low middle income countries. And imposing a barrier to work based on vaccination status is probably just a killer to industry, productivity, and including public service in our kind of setting. So next one, please. So as I said, there was also a mention that I should talk about what does this mean in terms of the public health implications. So going through the main criteria of what we call public health prevention, Dr. Chaponda mentioned already, we need to continue with good hygiene, sanitizing, washing our hands, barriers, masks, quarantine, and also vaccines, dosing, boosting, and also consideration of now polyvalent vaccine that comprises more of the variants than just a single, protein derived vaccine, which is not going to be very helpful, especially if we expect more mutations. But as I said in last year when we had this kind of talk, the good thing about nature is that the mutations are not necessarily a bad thing. It's a double-edged sword that sometimes the virus just mutates into its weakest form, and then the body just gets rid of it, and that's the end of the disease in a society. But we can never tell. Maybe the next generation of the virus will be more virulent and catastrophic. That's why we have to be ready and be always, on the alert in terms of prevention and treatment. So much work has been done now. WHO has recommended recently quite a number of drugs that have shown to work in clinical trials. Some of them are the old drugs that we have used for rheumatoid arthritis, for example. But we know about steroids from the Oxford studies, and also monoclonal antibodies is something that can be used. And then we know about oxygen therapy and its efficacy and how it can also supplement the other treatments. This third point I want to make is about rehabilitation, which seems to be something that is being ignored, not just in Africa, but I think also in publications from the West. People who have been affected or infected with COVID have gone through a lot of emotional and social or economic trauma. And some of them are still in shock. Some of them are jobless. Others are basically just in nowhere. And psychiatric illnesses in this kind of setting will be really augmented because of lack of structures to look at this aspect of psychological and psychiatric care, and also management of what we call long COVID. There's a lot of patients from the previous waves that are not still feeling very well. They have sequelae, and their lung function has deteriorated, and they have neurological problems and all that. And that requires some attention in terms of public care. Now, in surveillance, I mentioned about surveillance, and I think when we come to surveillance, the main issue is to do what I prefer to call smart surveillance. For example, in countries in Africa, there's no point to label countries like Malawi or Mozambique and others to have infrastructure to be genotyping each and every bacteria or virus they come across, because that is more of an academic exercise, and then you detract them from the actual work that is required of looking after the sick and doing proper research to bring out solutions that save lives. And so, but having said that, it is very important that we have genetic testing that is of quality, and we have hubs that are sharing information, and that was why the Omnicron issue came up very quickly, and people dealt with it very quickly because South Africa was able to share the data it has, and the decisions were made. And lastly, then takes me to clinical research. I think we still need to look at what has happened and what is happening so that we can set proper research questions that can require and they deserve funding to answer certain questions that still linger around if we are going to learn from the epidemic. Because I think what COVID has done is to provide opportunities for us to start working in a different way, and we can use those ways to also fight other diseases that have been long standing before COVID was around. Next slide, please. Oh, so these are some of the questions that I think we still need to answer. Clinical presentation and diagnosis of the disease. Are current diagnostic tests effective in detecting Omicron and the future variants? We still don't know. We may be still missing a lot of infections, especially those that we call PCR negative or something. And these are issues that need continuous research to make sure that we don't miss what is vital. Is the Omicron clinical presentation worse than the predecessor? We have already answered that, and we're seeing a lot of research published. But what about the future variants? Will they be catastrophic than what we have now or not? Again, that is what we should be looking into. Are the current treatments still effective against Omicron? I think the evidence is yes. And as I mentioned, there's quite a number of now, new added on treatments that WHO has recommended, and certain things that we thought were working have been abandoned. Next slide, please. Yes, so immune responses, if you go back one more. Yeah, so in terms of vaccines, and again, we need to ask relevant questions around them. And I think when it comes to vaccines, it's really about bringing about a vaccine that is easy to administer, that covers most of the variants that we've been talking about, and is affordable and is acceptable. It's quite difficult to have something that fits those kind of broad criteria but whatever we can find and lay our hands on that brings herd immunity and reduces the attack rates between populations would be good enough to hold on to until the future. Next slide, please. Yes, so this will be my two last slides. I mean, having said that, again, in public health, the problem is that we still have the old problems that still continue to haunt us. And one of these is the issue of cost and deciding who is going to pay. As already mentioned on that slide, when I showed you about the coverage of vaccines and how it looks as of Monday this week, I'm not really convinced that this is how the world can defeat a disease. So, but it's an issue of money. And then we get in countries where the map is showing, you know, a good coverage, endless demonstrations, people refusing to get vaccinated, as Sarah mentioned earlier, including health workers, and then that also being used in the third world as a reason why they shouldn't get vaccinated if the source of the vaccine people are still fighting. So compliance will still be an issue, and we need good social science researchers to help us to come to you know, good answers so that they can lead us into designing policies and practices. The next one, I think that's my last slide. Oh, that just emphasizes, I mean, this is just not about COVID, but if you don't have the tax and you have to beg or you have to wait until something happens, that's really where we are now. I mean, with a lot of all these diseases. I shared with Sarah one of the publications we did when Omnicron was announced and the West shut their door to South Africa. Some of these issues I've mentioned are in there. I hope that will be shared to the members of MONA, because there was from the authors, some emotional tantrums in there, but you know, looking at where we are now and the announcements that the Prime Minister made in the UK, and what I've also heard being announced yesterday on French radios about what they're going to do in France. I mean, people will be sitting and say, but what the hell was that then? Because look where we are now. Everybody is reacting what they thought was, but that's science, you know, we have to move with it. And to us, it's a big lesson of how science intermingles with economics. And so now we're talking about One Health, really, of environment, us, and the viruses and the bacteria on the other hand. So this big triangle has always to be considered in whatever we do. I think I'll stop there and then be happy to take part into the following discussion. Thank you.
Thank you very much, Dr. Nyanda. Your presentation, especially around public health perspective with regards to managing what we are going through, is very enlightening, because there's always, what came to mind is that adage that says prevention is better than cure. And showing us the bucks at the end, that's where the cure is. And there's so much we can do in terms of prevention. And what you presented around wearing masks, washing hands, those are simple, cheap, easy things that we can do to ensure that we keep ourselves protected, where we don't get to the point where we are digging into our pockets and we don't have funds to look after ourselves. If our healthcare system is falling apart and we don't have the funds and the capacity to pay for the care of our people. So that is very crucial. This is something that we have to take away with us. I was just reading something known as the Swiss cheese. It's a Swiss cheese program. It's similar to what you were saying, that not one thing works, but a series of things. So the hand washing, the vaccination, the research, everybody doing something small works in the long run. So if we each can do our part, we can conquer this. Thank you so much, Dr. Tom Nyirenda. And I know people might be burning with some questions. Please put them in the chat if you have any questions. And just wanted to say thank you to the audience as you're coming in, you're trickling in. You've been polite enough to keep your mics off. I really appreciate that. So can we continue to keep our mics off? Keep your cameras on if you'd like to. We are recording the session. If you have any questions, once again, please put them in the chat function. We will have a Q&A session at the end. We have one more speaker before we get there. And last but not least, I would like to introduce a woman I'm extremely proud of everywhere I go. This is Charity Gladstone. She is the president of MUNA. She is the visionary, the woman who carries us all, our mother, our sister and a friend. She is a registered nurse, a matron within the NHS in the area of cardiology and respiratory. She is also an advanced nurse practitioner. She is a critical care specialist nurse with interests in acute medicine, primary care, and public health. Charity, the floor is yours.
Thank you. Thanks so much, Salah. So I'm going to talk. Mine is just a talk. It's not a presentation. So I'm going to talk about vaccination as a condition of deployment for healthcare workers. As you are aware, this will be coming soon. And I know that this is a very difficult conversation. It's caused a lot of trauma. And one thing that I wanted to say to or to mention is that this ruling is not, it hasn't been laid down by the NHS. It has been driven by the government. It is now legislation in England. So some people are asking what vaccination, what is vaccination as a condition of deployment? So in a snapshot, in late 2021, the new regulations came into place, and these were agreed by Parliament, making it unlawful for the employer delivering CQC regulated activities, which I will mention along the way, to deploy an unvaccinated NHS worker or worker in face-to-face role with a patient from the 1st of April this year, 2022. So these rules are commonly referred to as VCOD, in short, vaccination as a condition of deployment. So the Department of Health, as a legislation, came up with this legislation, as I said, on the 9th of November in 2021. It laid down the regulations to amend the Health and Social Care Act 2008 and also 2014. This act, in a snapshot, states that the health and social care can only employ individuals who are vaccinated to provide CQC regulated activities. So individuals will be required to produce evidence that they've had a vaccine or they've had a single dose of vaccination within a specified period of time. There will be some exemptions as well, which I'll talk about. So days are running very quickly. So there's a timeline which I'll also talk about, but as of now, by the 3rd of February, which is only, I can say 2 weeks from now, individuals will need to show that they've had at least a single dose of COVID-19. And they're expected to have their second dose on the 31st of March this year. So these regulations, as you are aware, they're going to run in conjunction with what's already in place, because in the care homes, if we remember well, some of our colleagues that we know or relatives or friends have lost jobs because they're not vaccinated. And this will apply across the landscape of the public NHS and independent health sector. Because the way it talks then that, or do you know what, if this becomes mandatory, I'm going to work in independent sector, but no, this is going to run across. So when you think about it, and after listening to both Mas and Tom, we're aiming to protect the vulnerable, and also us as individual health workers. We've lost our colleagues due to COVID, and some doctors, nurses, porters, cleaners, they've been equally affected. So the government had to do something to make sure that we limit the spread of the virus. Settings affected will be hospitals, GP practices, persons' homes. So everywhere where the CQC regulated activities will be affected. And the other question that comes into mind is the scope. Who do these regulations affect? So this is going to affect health and social care workers who are deployed in respect of CQC activities, who have direct face-to-face contact with service users, employees working in non-clinical ancillary roles, so those who enter the premises, let's say in the hospital or in the nursing homes, who may have social contact with the patient. So this can be receptionists, ward clerks, porters, and cleaners, and even locum bank agency workers, independent contractors, students, and trainees. So it's a big thing, and I think we really need to think about it deeply. So there are some exemptions, but for those exemptions, there will be some, you need to have a formal procedure. So you need to seek advice from the GP and also from the requisite website. You need to have an NHS pass, but with the NHS pass, you also need to carry out an additional confirmation letter from your doctors or GP to ensure that you're fulfilling that criteria. So with exemptions at the moment, under 18, those that are clinically exempt, pregnant women are also being exempted for at least 16 weeks postpartum or post-delivery, putting it in simplistic English, I should say. And those that have been partaking in COVID vaccine trials as well. So members of staff will need to fulfill mandatory exemption under local agreements. So this will be done by wherever you work with occupational health teams. So it's the duty of employers really to keep records of vaccination as part of staff employment and as part of occupational health records. We know we're supposed to have Hep B vaccine and some evidence of BCG, so it'll be the same. So as if you are employers, if there are any employers here, you need to have some systems in place so that you can ensure that you're compliant, and if there's need for further reviews and even exemption of employees, those systems are in place and are robust. So you need, as employers as well, we need to provide appropriate information and access to advice, and as well as give our employees opportunities to get those vaccines. So we've got a duty of care. So I did mention about CQC regulated activities earlier on, and these are, just the usual personal care, provision of accommodation for people requiring nursing or personal care, those with substance misuse, mental health issues, surgical procedures, diagnostic and screening procedures, management of blood, transport, midwifery services, slimming services as well, and even places where they're doing termination of pregnancies. There were some key dates within this regulation. So by the 6th of January, this is when the regulations came into force. There's a grace period from the 6th of January to allow staff and employees to increase vaccination uptake, hoping for the full implementation by the 1st of April. And on the 3rd, by the 3rd of February, everyone should have had at least their first vaccine, so that by the 31st of March, you should have had at least the 2 vaccines. So really, from the employer's perspective, one of my roles that I do, so from the 4th of February, we'll be starting the final formal processes. I will explain a little bit that further on. So on the 1st of April, there'll be full implementation of vaccine as a condition of deployment. So, just you are aware. So within the NHS guidance, they set it up into 2 phases. So phase 1 is just what we are doing, maximizing risk assessment, assessing the level of risk, requisite policy and guidance, just making sure that people are aware. And phase 2 will be looking at service transition from where we are at now to now what we're looking at as a vaccinated workforce. And this is going to apply across, as I said, across the healthcare landscape. So from the NHS, the guidance as well, from the 1st of April, it will be unlawful for an employer to deploy staff who continue to remain unvaccinated in the areas that I've mentioned without an exemption. So you can't just refuse, and you can't refuse to disclose your vaccination status if you're in a face-to-face role. So it will be unlawful. So we're hoping that by then we'll have reviewed all objectively all other exemptions and assess individuals equally, providing them with all the necessary guidance and information. There've been some questions where people are asking what the unions are doing about this. The only union that I've spoken to so far with regards to this is Unison. They've informed me that they were trying to influence the government not to introduce this vaccination as a condition of deployment for staff. And they have taken a lot of national and regional print since when this mandate was being muted in 2020, and they're continuing up to date. But at this stage, it's highly unlikely that the government will reverse this. They've had meetings with the senior government, the Secretary of Health, and also Minister of Workforce in these discussions. And there've been a lot of several parliamentary briefings, both ahead of this formal and regulatory process that's coming through. So there are some calls to delay or extend the grace period for NHS employers, but as of today, the 21st of January, and as we're talking now, the date still remains. Nothing has changed as far as I know. I don't know whether anyone knows anything different from the group. So what we can say, or what I can say as well, is that these are very difficult conversations as we have seen and as we continue to see, because they're very strong opinions. What I'm trying to say as well is that it's a personal choice. But if you are in a clinical facing, employee, you might be redeployed. Employers are trying to put some robust and rigorous processes to try and save your jobs and also to protect you, but there's a chance that you might be moved to a non-clinical role. And we have to think very deeply on how this is going to affect our revalidation and also our registration. There were some talks that maybe we'll be having international staff, which we are anyway, but the expectation for those as well is that they will be expected to be vaccinated by MHRA approved vaccines. If they're not, they'll be given those vaccines here, and they'll be given a grace period as well. So Malawi and UK Nurses Association advice is we support vaccination in health and social care. We believe that vaccination is safe, and we encourage our members, those who do not have medical exemptions, to have their jab. we are not going to advise our members not to be vaccinated against their will, and will not advise our members to refuse vaccination. This is an individual decision for staff and for our members, and for those members to make alone. We will support you with an informed decision, but at the end of the day, it's your choice. So I know these conversations are difficult, but we have to be compassionate and kind, and sometimes they best delivered in a one-to-one place, or that safe space. There are some difficult questions, and I just received one, I posted it there, but I know I've got these experts that will help me, and I think I'm banking on Dr. Chikwete as well, who might be online to help me if I get stuck. So thank you so much. That's it from me. Thank you.
Thank you so much, Charity, for that comprehensive explanation of what we are going to expect in the next few weeks. It's not even months now, it's few weeks. It's already started, and it's answered some of the questions, and I think some of the fears that some of our members have been alluding to already. The question is, it still remains to say, this is something that's just happening in the UK, isn't it? It's not worldwide. Somebody did put in the comments on the side there that this is just something that is happening here. They stated, I think it's Joyce, with these new changes, that we should just live with the virus, that Parliament will change this. This is only UK, not worldwide. They are 70,000 unvaccinated in the NHS. And that number alone, we have to remember that the NHS is struggling already with employing and recruiting nurses, and conditions are being put in place that if you're not vaccinated, you're not going to be clinically facing. What would that look like? What would that mean? So, you know, we're waiting to see what will happen. And do you happen to know what backup plan the government has? If the 70,000 say, okay, we're not getting vaccinated, you're pulling us off the front line, what will happen to the health system in that respect? Do you have your ear to the ground?
Don't quote me on this, I know it's being recorded, but there's some roles that we were hoping we could fill them easily, but those are the roles that are very difficult to recruit in. So that's where we are, or the unions are trying to negotiate for extension. But like in my trust, I just know that there's just one doctor that's not vaccinated, so which is pretty good. But there are a few nurses that are not vaccinated, and I can't even afford to lose them. They're absolutely excellent nurses. But there was talks about a backup plan that the army might fill in the plugs, but not all. Who knows?
Okay.
Can I come in with a comment?
Go ahead. Yeah.
So without trying to be draconian about it, if we look at who is admitted into the intensive care, these are the unvaccinated. That's the reality of it. It's not that the government, and it's not just the UK, Macron got into a lot of trouble for the same. It's not that the government has just woken up and said, you know, these measures are being put in because we want to be unfair to people. It's the reality. And as medical professions, you know, we should be looking at vaccine hesitancy, as Charity said, maybe on a one-to-one, and addressing the issues, because these are the people who are dying. These are the colleagues that are ending up in the intensive care. So yes, there is individual choice, but there's also the choice to life, and there's our responsibility. So I think we should be helping bringing the numbers of people that are refusing to have vaccines or are hesitating for their good. It's not just because the government has legislated so. We should be saying, what is the reason? Why have the medical profession advised the government to take this stance? And it's not just the UK.
Okay, thank you, Dr. Mass. I'm actually just going to go into a question, a really big mouthful that was posted, which I think either yourself and Dr. Nyirenda might jump into. So this one came in anonymously. The individual stated, they were talking about the Israel study, that it shows that it has shown that natural immunity is over 20 times more effective. Vaccine antibodies are only shown to be effective, and vaccine antibodies are only shown to be effective for 10 weeks. So it's not 1 or 2 vaccines we have to sign up for. They're asking the question, when will this stop? Individual vaccine status won't affect someone else's illness. Are we disregarding the fundamental principle of bodily autonomy and accepting manipulation and coercion as acceptable medical practice? Where is the choice? That is a mouthful. I'm going to leave that to you.
Sure. If I can start, I'll add some comments, and I'm sure Thomas will add more to that. So there are several points that are being brought in there. What about natural immunity versus vaccine immunity? I'm just going to bring out a point that Thomas already talked about that people are forgetting to talk about, and this is the long COVID. So if you say, I want to go with natural immunity, I want to get COVID and that's how I'll get my immunity, there is a risk there. There is a risk that you will not just get COVID, you will get all the complications that come with it, including long COVID, which affects the lungs, which affects the mind, their chronic fatigue. There's lots of problems that can come with saying, this is the way forward, I just want to get this illness. Yes, there is that chance that it might be a mild illness, but there's that chance where you have all these long COVID complications, which are not great. For a clinician like me who has treated patients with this, it's not a great thing to see. So I would always advocate that the vaccines are safe. We don't have those sort of safety concerns, and therefore we should be saying that we should go for the vaccines rather than saying for natural immunity. And the second thing about the duration of immunity, it's not 10 weeks. We have long evidence. We have evidence from the last 18 months about waning over 5 to 6 months, and then you get boosters around that. Thomas, do you want to add in?
No, absolutely. Thanks, Mas. I think you have touched the point there. And the addition I would want to make is that, as I already said, I think we are in a very unique time, and what COVID has provided is also lessons on how we can do better in other diseases. So let me mention the 2 diseases that we are all very conversant about, TB and HIV. So my background is TB research. Now, we know that there's vaccines in TB, and those vaccines do not protect the children 100%. And there's always breakthrough infections, and that's why we have TB in children. And after 5 years of age going up, the protectivity of BCG wanes over time, and that adults are no longer as protected as they were when they were in the ages below 5 years of age. Now, what prevents people to get a booster? It's just because scientifically we haven't come up with a better vaccine. If we had a better vaccine that works in adolescents and then works in people who, prima gravida or people who have advanced in age, I personally would say that would be now a new norm, that you get BCG when you're under 5, then you get an adolescent vaccine when you're in school, and then when you are in the workplace, you're an adult, you get a booster that protects you from getting TB. As we know that when you are born, the risk of you to get TB before you die is about 10%. So we want to reduce that risk. But if we have the resources, why shouldn't we get them? And COVID has provided this window of opportunity to explore that. When all the politicians were shaken and everybody put their resources they had, emptied their pockets and produced all these other vaccines. But instead of taking the opportunity, we are saying, no, we don't want to have them. I think that's really not helpful. But I want to throw this also to us health workers. I think this is our health worker problem. We are the ones that understand what I've just been explaining, for example, how these things work. but we don't have the expertise of how to better communicate this to our peers that do not understand. And even among us, not everybody understands this. And they also put a resistance things around themselves, which doesn't help the situation. I think what modern science in COVID has shown us is that this is really possible. You can actually follow very quickly an epidemic at every stage, every 6 months, and have an intervention that is going to protect, as Mas said, those that are really vulnerable and those that can easily succumb. And I think this is where the window of opportunity is. It's just unfortunate that liberty and freedom and everything else is being thrown into it. But I think it makes the work for us health workers even more challenging, and we need to think about how we can help the society overcome this. I don't think we do enough at all. I mean, there are so many areas we don't do enough. I mean, not all of us, we are doctors, we're trained in nutrition, but patients expect us that when they walk in our clinic and we say, okay, now you have to follow a better diet so that you don't have a heart problem anymore. They want us to lay it out and say, you must eat this and this and this. We don't have that training. And that similarly, we need to recognize that here we are falling short, and we need to bring in expertise to help us in this area. I would end it that way. I know it's more controversial, but I think we really need to look inside as well before we blame people from outside.
Okay, so I've seen a couple of questions that sort of piggyback on one of the words that you used. You were talking about a pandemic initially, that this is what COVID has been for the past 2 years. And moving forward, it seems that different governments want to downgrade it, including our government. There's talks about downgrading it to a common flu. And if we go down that path, the flu vaccination is not compulsory. If we're going to downgrade COVID now to something that we're going to have to live with, we are talking about taking off some of the restrictions that are there. So it's no longer compulsory having to wear a mask and so on. Why, with all these things, with all these changes moving forward, why is it that with COVID right now, they are making us feel that if I don't get my booster or I don't get my COVID vaccine, I'm uncompliant? I think this is where the fear is happening with our own staff, because I cannot sell something to my patients if I don't believe in it. And if I'm not convinced as a healthcare worker that, you're telling me it's a pandemic, and then two weeks down the line, you're going to tell me I can walk around without a mask. Oh, it's just like the flu. There is a lot of confusion there. There's dichotomy in the brain. I'm trying to, you're trying to make sense. What would you advise? This is just a question in terms of advice. What would you advise those of us who are on this group right now in terms of moving forward to err in caution in how we can manage this current pandemic before it becomes an everyday flu?
Do you want me to go first, or?
Yeah, go first this time. I'll piggyback on the back.
Yeah, so Mas will compliment on what I'm going to say, but I think the job that he has and we have is really, as scientists, to expose the enemy. And once you expose the enemy and you build, as he presented in one of the slides, the wealth of information, and then information is power. Then once you empower the population, then you leave it in their hands. So when I heard Prime Minister talking, I thought he is coming from that angle, really, that we all know that if you visit a bathroom and you don't wash your hands afterwards, you are a risk to yourself and a risk to your close ones and any contact you have. Now, maybe 50, 70 years ago, you needed a police officer to actually check whether people are washing hands after they leave the bathroom. But now it has become a public health norm. And so it's up to the general public to internalize the measures that we have put in place. And that's not the end, as we know, we don't know everything. We still have to provide answers to a lot of other challenging issues. So now, what you're saying to the general public, if you want to protect yourself, mask, sanitize, and isolate whenever you have signs and symptoms, or you know that somebody has signs and symptoms, don't visit them until it is. So now it's up to you. It's up to the general public. And I think the health workers should also understand it in that way, that they have a role to play in educating others. Now the challenge we will have is the perceived educator is the first resistor. That is going to be a problem, because then the chain is going to be broken. Science has produced the evidence, which you have to put into practice, and somebody must teach it to the general public. And of course, we can, after that, we can have follow-up campaigns like we normally do in HIV about, oh no, ABC, wear a condom and this, and have national COVID days like we have with other diseases. That will be follow-on activities. But here now, it's leaving it in the people's hands. And he said, I think he said, when I listened to him, he said, it's up to the British people to decide now. The recommendations still remain, scientific recommendations still remain, and more are going to come. So I think that needs to be understood from both sides, really, and the general public needs to understand that when now the recommendations that science has produced is left in their hands, it's up to them to exercise it within their liberties without also putting other people at risk. I'll stop there. Thanks, Mas.
Thank you. So if I can just add a little bit to the point of downgrading it to a flu. So one, let's put the politics aside. There's reasons why, for political reasons, it's good to quickly move to let's stop restrictions, okay? So let's put that aside. What I would say is we should exercise caution. On the slide that I presented about the good, I clearly said Omicron is a milder disease with less hospitalizations, and that there is a promise that hopefully this is the beginning of the end. Everybody is sick and tired of 2 years of COVID, and everyone wants it to end. But we must be cautious. The caution is this thing that we're saying, let's downgrade it to a simple flu, has killed 5 million, over 5.5 million people globally. 5.5 million globally. That premise to let's downgrade it, it works on the back of we have vaccinated our population. So we know that they are not at risk of hospitalization and death. It's not, we're downgrading it with no other measures. All those other measures that Thomas has talked about, including hand washing, etc., go hand in hand with, and we have vaccinated. So I think we should be advocating for caution. We should be advocating to say, carry on these measures and hopefully this thing will go away. But it will not go away with just, well, hand in the air, it's just today politically decided that it's a flu. It's not going to go away that way. We have to do those measures, including vaccination. That's part of that equation.
Fantastic. I think I'm just going to echo what both Thomas and Mas have said. When Sajid Naveed was being interviewed on TV about the downgrading, and I remember the interviewer asked him that, okay, so when we take off the mask restrictions and then I meet you in Tesco's next week doing your shopping, will I see you wearing a mask or not? And he actually said, I will choose to wear a mask because that is my choice. Even though we have downgraded, but I would choose to wear a mask. And I think if we see a lot more people who are role models, and we are role models within our work and in the capacity of what we do, implementing things that we had been implementing for the past 2 years and being cautious in the way we're moving forward, the general public will pick on that, and hopefully people will make the right decisions. So I know somebody down on the chat made a comment about where is the respect of individuals' basic human rights and making their own choices. This is where people are going to have to make their choices on what they want to do with protecting themselves and generally protecting other people. I'm going to ask a slightly different question because I know those questions will keep coming. They'll keep coming. We will not get an answer that will satisfy everyone. Once again, it's an individual's choice. Somebody asked a question around what happens to people getting reinfected? Why is that happening? So how many times can somebody get COVID?
I can start and others can join on that. So it's not a simple answer, it's multifactorial. Some might be because your immunity has waned from the time that you got your second jab, for example, and waiting for a booster. We know that the immunity will last about 3 to 5 months, so that's one. And we know that different people have different waning points. So some people might wane at 3 months, some people it might be 5 points and can get reinfected. Two, if your infection, if somebody hasn't been vaccinated, for example, had a mild illness, I think I talked about this with Omicron, that if you had a mild illness, you may not have primed your immune system enough to fight the next infection. And remember, going back to the vaccines, that they're not 100% protective against acquiring infection. They're 100% protective against death and hospitalization, but not about acquiring infection. So you can get infection several times. So coming back to the point, how many times are we going to go on boosting until the variants stop, until we have eliminated COVID for everyone? That includes Africa, that includes low-income countries. And I think many countries are now beginning to realize that it's not over unless it's over for everyone. And that's really, really important.
One of the biggest reasons that a lot of people that I've been having conversations with regards to why they don't want to get vaccinated is issues around fertility, issues around how they fear the vaccine might actually affect women's menstrual cycle. Just wanted to ask, do you have any up-to-date information that might subdue some of these fears with regards to effects of the vaccine on fertility and effects of the vaccine on women's cycle? Because I do know they were, I think last year in February, Pfizer was undertaking a trial for pregnant women. And I don't know if you might have heard anything about that in terms of results. Any updates?
Do you want me to step in, Thomas? Do you want me to talk about this?
Yeah, sure. Please go ahead.
So there have been a lot of publications, so both in cohorts, so people who have received vaccines and then fallen pregnant or around the time they became pregnant, and then also, as you talked about, the Pfizer trials. So we have data for over 8,000 pregnant women. So there was no problems with conceiving, people who were before they got pregnant, getting pregnant, but more importantly, the outcomes after pregnancy. There were no abnormal babies, there were no abnormal miscarriages, there was no effect on fertility. So to date, the data that we have is that this is safe in pregnancy. There are no fertility concerns for men or for women. And WHO had an interim, and then they had a definite recommendation for the vaccine to be given in pregnancy. The most important thing I think to also put in there is that pregnant women are more likely to have severe COVID. So that really should not be downplayed, that we know that pregnant women have severe disease, and it's important that they are a priority group for vaccination, but there are no negative outcomes pre-conception or post-conception or stopping conception. Thank you.
Thank you. Dr. Nyirenda, do you want to add on to that?
No, I think Mas has covered most of what I also have heard about. Maybe if I can just go back to the previous question of why other people will still continue to have COVID infection. One of the reasons also is we don't know, for example, the influence of genetic variability on the vulnerability of this disease. It's a new disease, and what I mean by that, we all know about certain families where 5 people were, had disease and they succumbed, and they were in contact with another family, but the other family, all of them have survived. That raises questions about the differences in genetics and how it plays in terms of resistance to the disease. But more future research will give us answers in things like that. And I just want also to mention that even in clinical trials, when these vaccines are tested, it's not a one-size-fits-all. All people who we say are protected, their titers of immunity, immunoglobulins, they are not uniform, but those that are protective, they're over the place. So you can imagine in a scenario where somebody is genetically not responsive and okay, they have low titers, they have been vaccinated, but some event follows in their life that naturally brings the immunity down, and it happens to all things like flu anyway. We can have flu immunoglobulins or titers or whatever it is, antibodies, but we all go through these life cycles that it goes up and down, and when it's down, the virus takes advantage and kicks in and all that. So even for COVID, it's not going to be foolproof. And so we should expect people, and it has happened already, people who are vaccinated getting a second or third infection. But what is important, I think, is what Maz said earlier on. What is the primary outcome that we want? And it seems in COVID, what we are interested in is prevention of severe disease and adverse outcome, which can be a total incapacitation or death. And those vaccines have shown that they are really good at reducing and protecting people that are vulnerable. So I just wanted to add that one. Thanks.
Thank you. I have one last question. And when I was asked this question, I had to reframe it in my mind. So people are coming with logic where 1 + 1 = 2. And a lot of family members or individuals that I know from Malawi, especially in Malawi, they are saying that they believe that people are catching COVID from the vaccine. And the logic being, we in the West are the most vaccinated, and yet we seem to have the highest number of people catching COVID. And there's been a couple of stories where people might have had side effects after having a booster or catch COVID straight after having a vaccine or a booster. How can we quell this fear? So the question is, can I catch COVID from the vaccine?
Thomas, you can go first.
Well, you can have signs and symptoms of COVID from the vaccine, but you cannot catch COVID because I think the mechanisms of infection and the vaccine are different. The meeting point is the expression of the virus antigens to your immunity. So I wouldn't call that, well, you can call it artificial infection, but it's not in a form that it comes when it is a natural infection. But you do have signs and symptoms. I mean, if every vaccine, because it's playing with the immunity, does that. And that's why when the children get vaccinated, we advise the mothers to watch the temperature and give them analgesics and antipyretics. So that's the fear. And I'm afraid these kind of rumors, it's not just in COVID. We have, when you heard of these stories about the WHO epidemiologists being beheaded in Congo because they thought they were bringing Ebola, you know, it's the general public are right, actually, basically, because they don't understand the business. And just you coming in their neighborhood and changing their lifestyle and say, now we have to start injecting you, and they see more people dying from other causes, which can be coincidental. They must be on guard, and they're right. And it comes back to my point that I think we take a lot of these things for granted, but because we understand them, then the general public understands it. And there is the weakness in the whole thing. So coming to your question, which is, I think, the crunch of the matter, that how can we quell this? I think we really need to go back and come back with good explanations of how immunity is elicited in a simple terms so that people can understand. If you think about Malawi, for example, many of us have been traditionally vaccinated. I mean, you go to school, somebody has to call Singanga and, you know, make escalations and put something in your skin so that you become not, you know, you go to school and you're protected from mafiti or things like that. That's, for them, that's, you know, the type of vaccination that they understand very well, because it's well explained at a community level that everybody is convinced. If we can convince our customers, who are the general public, the way they get convinced about Mpini, Singanga, and protection and things like that, then we will say we are doing a good job. And this is where, for me, I think it's an area of diversifying the role of health workers so that they are supported by people who have special kind of skill. I don't think that kind of job should be put on me and Mars when we are doing other things in the lab and things. I think that doesn't work. It needs to be thought through so that, you know, this hesitancy issue, which is becoming a global problem, especially now during social media, where people can quickly exchange ideas, needs to be tackled efficiently so that we can be moving forward in these interventions. Over to you, Mas.
Thank you, Thomas. I agree completely with what you've said. What I usually say when someone says, can I get COVID from the vaccine? Again, keeping it very simple, like you said, the first thing I say is there is no live virus in any of the vaccines. There is no live virus. There are parts that are genetically coded, parts genetically coded for that virus. So there is no live virus. That's the first thing. The second thing, which you talked about, all vaccines, and this I say is a good thing, all vaccines are immunogenic. So when I give you a vaccine, your body reacts to it with fever and you feel that you might need a paracetamol for a day. And I actually say to them, this shows the vaccine is working, you know, the fevers, but it will last a couple of days. That's not COVID. We know that COVID doesn't last a couple of days. This is the power of the vaccine. That's as simple as I would give it. And then the bigger question is when people say, well, but I know somebody who got COVID like maybe 3 or 4 days after. And that's the harder thing to explain, that in some people, at the time you're putting the needle in, they're already incubating COVID. They've already been infected. So the vaccine won't stop that early disease. It's just because some people don't have symptoms until maybe day 3, day 4 with Omicron, or day 5 with Delta. So coincidentally, by the time I was injecting you, you were already infected. And again, the more important thing, the vaccine doesn't stop you getting COVID. It's stopping you getting, well, 96%, if it's Pfizer, for example, it will, but it stops you getting severe disease. That's the important thing. It's stopping you getting severe disease. Again, we need to teach our people to start thinking that this is the new thing. This is the important thing. You will not die if you get a vaccine. But if you say, I'm going to leave it to chance, there is a chance of dying.
Oh, you're on mute, Sarah. I just wanted to bring James. You wanted James Chifuese. I think you've typed, but maybe it might be better explaining. Are you able to speak?
I am, yes.
Okay.
So it was just, I think, 2 points. One is around, I think, the government plan and the dichotomy that Salah said in terms of, one moment we're saying, oh gosh, we've got COVID, have all these restrictions in place. And the next moment we seem to be saying, oh, well, everything's throw everything outside the window. So I think the government plan is basically predicated on the fact that case rates in the UK are falling, hospitalizations are falling. We seem to have peaked in terms of Omicron, and then the government has to consider other things, for example, stresses on the workforce and the system as a whole, including the economy. And if you look at the things that have been changed for Plan B, there are three main things. One is working from home. The other is vaccine certification, and then face coverings. So if you look at working from home, what the data has shown is that there is some inequalities. For those that are better off, particularly people outside London, they are probably able to work from home. Certain industries and people who don't have the ability to adequately work from home, there is some inequality there that's been identified. With certification, and this was mainly for large-scale events. So you didn't require certification, for example, to enter bars or restaurants or the supermarket. And it's these, large-scale events, or you're going to a concert or whatever. But the data seems to have shown that that has a small effect in promoting vaccination. And the other bits around face coverings, they're still recommended for use in crowded spaces, useful to use them. And I think, and even looking at schools and so on, that, we deal with outbreaks and so on, there's still, schools are basically saying, look, we are going to carry on using them. And for many people, I think they'll decide to carry on using them. So as I think Mars and Thomas alluded to earlier, COVID is not over. And even you might have even heard the news today that on Wednesday, able to identify a new variant under investigation. So it's not a variant of concern, but it's under investigation, the BA2, which is a sublineage, a variant of the Omicron variant itself. And that's being studied at the moment. So COVID is not over. And we must not forget the fact that vaccination was a big game changer. It's the thing that changed things for us at the start of 2021. So those are things that I just wanted to bring about in terms of vaccination and that COVID is still here, that vaccination has been a big game changer for us, not just in terms of keeping the workforce going, but also in terms of promoting keeping people alive, and so it's important to pass that message that COVID is not over, and vaccination, let's not forget the key role that vaccination played for all of us. Thank you.
Thank you so much, James Chifuese. I've got my little one, so do bear with me. This is what working from home looks like. But on that note, I have one last unrelated question, but I think it comes into light because of the way the COVID vaccines came into play very quickly, how companies came together, governments came together, different groups came together to ensure that we had a vaccine very quickly. Now, the question, it starts to put light on other illnesses that have been there for years, cancer, HIV, and somebody put in their question to say, are we any closer to getting an HIV vaccine in light of what we're doing with COVID?
Do you want me to go first, Mas?
Yes, please, go ahead.
Yeah, as I said earlier, I would hope that that is going to also create a shortcut to all these iniquities we have seen in the past, especially not having an HIV vaccine for, I think, 4 decades now. And what actually is encouraging is that, for example, the German company BioNTech, working with Pfizer, their background of developing the technology was really to develop something against cancer, and now it's been applied quickly to COVID, and I think this provides an opportunity for scientists to also piggyback on the networks that have been formed that were never before there. We have now networks of scientists working across many colonial backgrounds together, and also breaking down the geographical barriers, crossing the continents, the oceans, and things like that. I think we need to look at how we can piggyback on that to really defeat other diseases. Because the point also that is hidden in your question is how much damage has the focus on COVID caused in other disease programs. COVID attention has damaged malaria programs, it has damaged HIV programs, it has damaged family health. A lot of people miss their contraception during lockdowns, and we have to deal with the baby boom sometime this year, all that kind of things that we really need to put into context. And at one point, we have to say, all disease control is linked. You cannot look at one disease. So how do we now benefit other diseases that have been left behind? We don't want to leave anything behind, just like the Sustainable Development Goals say, because this is the main theme there. One of them is not to leave anybody behind. We shouldn't leave any society that is affected with any one particular disease behind, because that creates imbalances that shoot us in the foot later. So I would really, if I was given a mouthpiece, this is one of the strongest messages I'd be saying to our politicians and others, to still build stronger bridges between different faculties, so that we are able to normalize. So HIV vaccine, long overdue, a beta TB vaccine, long overdue, and there are so many other diseases that we are talking about development of vaccine that maybe they're just on the shelf. Nobody wanted to fund because it's not a sexy disease. Let's start talking now. Thanks. Over to you, Mas.
I think that's a very comprehensive answer. I think the legacy of COVID will certainly be building on new technologies that have allowed us to make such amazing leaps forwards in 18 months. Hopefully that can be used in other disease processes. The word of caution I'll just add is these are different viruses. So it's not that people are being lazy. People have been working on an HIV vaccine for a long time. The difference with HIV, hepatitis B, is that these are integrating viruses. They become part of your DNA, and that's very difficult once you've got integration. But that having said, I'm sure there is technology out there that looks at, certainly with Hep B and therefore with HIV, that there'll be technologies out there that we can work on together if we put our minds together with the new platforms that we are using to say, let's look at integrating viruses and find solutions. So I'm not saying it won't happen. I'm just saying it's slightly different, a bit more complex, but it can happen. It can. I'm hoping it will happen as a legacy from COVID.
Thank you so much. And I think one of the other legacies from COVID is the collaborative work and how it's actually shown a light on the work that you, our Malawian doctors, are doing here in the UK, in Malawi, in South Africa. And yes, I completely agree with Charity. Dr. Thomas, for Prime Minister, we do need to have your voices being heard in areas where decision making is made at a strategic level within our countries. So this is one of the legacies from COVID. I am just keeping an eye out on the time. I know we've gone a bit over because the conversation has been invigorating. But what we will do moving on is that we will continue to ask you questions, but this time we're going to write your answers out on a pamphlet. So watch out for an email from me, Dr. Mas and Dr. Thomas, because questions are still coming in. Oh, I've got a hand from Angela. Okay, Angela, I'm going to give you the floor before I ask Mas and Dr. Thomas to say one final thing before we close. Go ahead, Angela.
Hi. So I just wanted to say I work as an allergenist specialist. So a lot of people are worried about side effects and about reactions. We've had a surge in referrals since the 6th of January, because obviously people are giving excuses saying that they are allergic to all these vaccines. So they're now being referred to our team. These are people who work in my trust. They're being referred to our team to be tested. And so far, we've been testing since 2020. And so far, I haven't come across anyone who's had a true reaction. So it's all subjective data and all information that's not true. I think sometimes people just exaggerate the symptoms and then they get referred to our team, but we're not finding anyone who is actually allergic. The one thing that is common in some patients is they're developing urticaria, maybe for 2 or 3 months, and then it just burns out. So that is one thing that we are seeing. But anaphylaxis and things like that, I haven't come across anyone who's had anaphylaxis. So we are giving people second doses, booster doses, because they've come with complaints saying that they've had the first dose and something has happened. They had all these reactions. So I just wanted to reassure people in this group, if they're worried about second dose, booster doses, that you can contact me if you want to talk to me privately.
Thank you so much, Angela, for quelling some of our fears. And it's really, really good to be hearing from experts on the ground. And you are actually giving us live data from what you're experiencing. So thank you so much for sharing that. So we are just about to close. And before I close, I would like to give both Dr. Mas and Dr. Thomas 30 seconds each to just sum up everything that they have said today. I mean, if you were to say what you said in 30 seconds, what would it be?
Okay, my 30 seconds. For this to end, we need to vaccinate. We need to encourage people to get their boosters. It will end, but vaccines play a major role in that. Everyone recognizes that vaccines play a major role, but it will come to an end. Thank you.
Thank you, Dr. Mas. Dr. Thomas, 30 seconds.
Yeah, from me as well, as I said, science is there for us, and science has produced what it can in this shortest possible time, and which is very valuable. And let's use it, and let's use it sensibly and not against us and against the population. It's the virus we should be fighting. We shouldn't be fighting what we think has been developed for our good.
Thank you so much. We have a common enemy, and that's the virus. Charity, I will actually ask you to say the final words for Muna as a close before I shut everything down. So you don't get 30 seconds. Yours is a final word.
So for me, thank you so much, everyone, for attending again. And thank you, Mas. Thank you, Tom, for keep coming and coming again. And I'm sure Salah will be contacting you because we've got some little plans that, that we need to do with yourselves, including Dr. Chipkwete, who's also on the line. So thank you so much. So for me, my takeaway home messages are vaccination works, boosters works, because we know within our community and within the Black and ethnic minority communities, they're saying they're not going to get boosted if it's another third, fourth coming. They've had enough. But listening to you both, these work and vaccines take time to develop. You gave a very good example on how BCG works and how immunity wanes as we grow. So these are the messages that we need to give back to our colleagues. The only disappointing thing that's happened recently in the media is that we've had very high profile professionals, in anesthetists, GPs, intensive care doctors coming online to say they're not getting vaccines. So I think that takes a little bit of confidence from everyone. But if we're better informed, we will have the confidence to challenge. Now, from Prime Minister Thomas, I take it we need to fight for vaccine equity in the world, because Omicron has just shown us in terms of the mutation that's going on. If we don't achieve that, we're not going to achieve where we want to be. So thank you so much, and thanks so much for coming.
Thanks, everyone.
Thank you, everyone. I just want to recognize Sally. She's the Vice President for the Kenya Nurses Association. So Nurses and Midwives Association in the UK. So thank you very much for coming and sharing within our talks today. And to everyone, our panel, thank you. We will reach out to you again. Thank you for your time. Absolutely informative. And to everyone who came today, thank you so much for your time. And I hope you've learned something and you've taken something away with you. And some of your fears have been quelled. And if you have any questions, keep bringing them to us. Let's continue to have an open discussion, because this is the only way we will defeat this pandemic. So from me and Muna, Ziko Mogwambili, Tathokoza, Tuona Naso. We'll see you again soon. Have a good night, everybody.
Thank you. Thanks, Sarah.
Bye.
Bye. Bye. Bye, everyone.
Dr. Thomas Nyirenda.
Yeah.
So late down in South Africa now.
Isn't it? Yeah. No, absolutely. Absolutely.
Okay.
Awesome.